in the practice of cardiology, are there instances where sedatives are used for various procedures?
Yes, cardiologists, we use sedatives all the time because we do procedures, and we want you to be comfortable during the procedure, so we give you medications to relax.
Okay.
And so you can be relaxed during the procedure and cooperative.
And are there instances in cardiology where propofol is used?
Yes, there is. When most of our procedures that we do, let's say angiograms, pacemakers, I do a procedure called a transesophageal echocardiogram where you swallow a probe into your stomach so we can look at your heart.
I'm sorry, doctor, can you say that term again and maybe
slowly
spell it for the court reporter?
Oh my God, I don't know. Okay. It's called TEE, just all capitals.
And it's a
transesophageal echocardiogram.
Okay, and what is that?
It's an exam where we actually put an ultrasound probe, like the gastroenterologist put an endoscopy into the stomach. We put in a probe with an ultrasound right at the end, right in your esophagus, because when we do an ultrasound of your heart through your chest, sometimes we can't see well through the tissues of your chest. So the esophagus and the stomach are right next to the heart, and we can get beautiful pictures with an ultrasound right in your stomach. So obviously we want you to, when I put something in down your throat, you want to be relaxed and sedated. So we give you medications. Cardiologists, in general, during our procedures, we are experts at mild or moderate sedation. Mild sedation is just taking a little bit of the edge off. You're still awake and talking. Moderate sedation, I'm sure you've gotten lectures already about this, is nicknamed conscious sedation or named conscious sedation, is a decrease of consciousness, but you're still able to respond to verbal, meaning talking, or tactile, touching stimuli. This is the level of sedation that cardiologists use in general in their procedures and what we're trained in. And actually, when I do, as a division of cardiology chief, one of our privileges is moderate sedation, meaning when you get a privilege at our hospital, you have to show that you've had training in moderate sedation, and you have to pass a written exam, and you have to be proctored or supervised in moderate sedation. And that's just, again, this is not deep sedation. Now, deep sedation is the next in the continuum, meaning the transition of sedation. And deep sedation is you're not responsive, you're only responsive to painful or repeated stimulus. And when you're in deep sedation, there's a chance that you can stop breathing because we're giving a lot more sedation. So most of our procedures are mild or moderate sedation, but one procedure in general that we always do that requires deep sedation is an electrical cardioversion. That's a procedure where you have an arrhythmia, usually what we call an atrial arrhythmia, or it could be a ventricular arrhythmia, but an arrhythmia, and we shock your heart back to normal. When we shock your heart, that can be real painful, so we want you to be sedated to deep fashion. So when that happens and we need to do an electrical cardioversion, we ask one of our colleagues from anesthesia to come over and put the patient to sleep with propofol so you're comfortable during an electrical cardioversion. That's the only time I ever see us using propofol.
One moment, please. Deputy Jones is going to hand
thanks.
Dr. Steinberg a cup of water.
Thanks, man.
Thank you, sir.
So then in your practice of cardiology, with mild or moderate sedation, that's the norm for cardiologists?
That's the norm for cardiology, yes, sir.
And in those settings where you're mild or moderate sedation, what type of sedatives are being used?
We usually use benzodiazepines.
And in your practice as a cardiologist, then, the only time propofol is used is, for example, in an electrical cardioversion, and when it's used, you would have an actual anesthesiologist administering it and present for the procedure.
We're required in both hospitals I practice in to have an anesthesiologist.
And you alluded to it, but I think you mentioned the word this continuum. Is that kind of a scale going from essentially light sedation to deep sedation at the other end?
Yeah, the continuum, as I said, is mild and then moderate, and then the deep that I spoke about, and then the fourth one is general anesthesia, where you do not want to be in general anesthesia. You don't want to be in any pain, so it's no pain. So that usually your airway is compromised and people are on a respirator. That's general anesthesia. So it goes mild, moderate, deep, general anesthesia.
Thank you, doctor. Now, in this case, then, you indicated you did conduct a review of the actions of Dr. Conrad Murray, the defendant in this case?
Yes, I have.
And you reviewed a number of materials as it relates to Dr. Murray's acts or failures to act on the date in question?
Yes, sir.
All right. Now, in your review, is it true that you actually focused your review simply on Dr. Murray's own words? In other words, his description of events from the transcript that was provided to you?
Yes. They gave me a lot of material to review, but I decided on my review I wanted to judge Dr. Murray on his very own words. So I relied solely on his testimony when I wrote out my report.
And in reviewing Dr. Murray's own words from the LAPD interview that the jury's heard, you in fact found 6 separate and distinct extreme deviations from the standard of care.
Yes.
With each one amounting to gross negligence.
Yes, sir. You want me to name them, sir? Or?
I think we'll go through them one by one.
Okay.
And you've listed all of these in your report?
Yes, sir.
Now, the first extreme departure or evidence of gross negligence you noted was that propofol was not medically indicated. Is that right?
Yes, sir. He was using propofol for the use of sleep. Propofol is, again, a very strong anesthetic medication, and we use it to facilitate, to make you comfortable during a diagnostic procedure. We don't use it for rest or for sleep or psychological reasons.
And on that issue of sleep and sleep care, did you note in your report certain requirements, aside from the propofol is not medically indicated, but just some basic tenets of sleep care?
Repeat the question, sir.
You indicated in your report that there requires discussion with the patient.
Oh, yeah. Before you give anyone before you do a procedure or give sedation, you need to get something called informed consent. When I do a procedure on you, which includes sedation, I discuss the risks, the benefits, the indications, and the alternatives of the procedure. Like that test I was talking to you about, the transesophageal echocardiogram, that the number one risk of that procedure, the procedure is rather benign, the number one risk is really the sedation, because there's a risk of you stopping to breathe. So I always explain that and explain the risks and benefits.
And that issue of informed consent, written informed consent, that's a basic tenet of competent medicine, isn't it?
Yes, sir.
Where as you said, the risks and the benefits of the procedure are properly explained to the patient prior to going into the anesthetic or the procedure.
Yeah, and we want you to understand what's going to happen. And unfortunately, anytime we do a procedure or give sedation, there are risks, because when we give sedation, it can stop your breathing. You can obstruct your airway, meaning you can lose control of your throat muscles, and your tongue can move back and obstruct your airway. And also, you lose control of what goes into your stomach. I mean, what comes up from your stomach. It could go into your airway and go into your lungs and cause a dangerous pneumonia called an aspiration pneumonia. So when I do a procedure on you, I want to understand, God forbid something like that happens, I wanted to explain that that was a risk to you.
And prior to your involvement in this case, and your analysis in this case, had you ever heard of any doctor using propofol in their practice of medicine to treat insomnia?
I've never heard of it.
And in your opinion, is the use of propofol as part of a doctor's medical practice to treat insomnia gross negligence?
Yes. It's indicated for procedures and patient comfort, not for sleep. That's extreme deviation from the standard of care.
And the second deviation you found was what?
A second deviation is that putting propofol, giving someone propofol in someone's home, unmonitored, without the proper equipment, medical personnel or backup, was also an extreme deviation from the standard of care.
Okay, and you've actually listed numerous things under that heading. So, in the home setting, without the proper equipment.
Yes, sir.
Without the proper personnel or staffing.
Yes, sir.
And without the actual physical observations of the attending physician.
Yes.
So let's go through these. And would each of these individually, although you list them as one extreme deviation,
yeah,
isn't it true that each of these individually would in fact be individual accounts of gross negligence?
I agree.
So let's talk about the lack of equipment.
Yes, sir.
And let's talk about that. What, in this type of setting, let's say in a hospital or an outpatient clinic or wherever the propofol may be being used, what is the standard of care as far as monitoring equipment that is required?
Okay. There's quite a few things we're going to go over.
This is a little bit vague. There's no clarification as to the type of sedation.
All right, I'll sustain the objection. Refine the question, please.
In regard to the standard of care, as to the use of propofol, okay, when propofol is administered to an individual, what is the standard of care as to the appropriate monitoring equipment that is required?
Okay. The standard of care for someone who's getting propofol should be monitored. There's a lot of things that you need to have monitored in a lot of different types of equipment. First, you need a pulse oximeter with an alarm, meaning a pulse oximeter. I think you guys got a lecture on that, right? A pulse
We're not going to have a dialogue with the jurors.
Okay.
So just
Sorry.
please answer. That's okay. Please answer the question.
A pulse oximeter with an alarm.
Pulse oximeter with an alarm, and you want to check it checks the oxygenation in the heart. And if it gets to be a low level, meaning the oxygen is low, then that's concerning, and you want to have an alarm saying, "Help! There's a problem." Dr. Murray's machine did not have an alarm, and so if you can imagine, if you have to monitor this person the whole time, you have to be staring right at that machine every second while they're on sedation and on propofol. So that was grossly negligent and extreme deviation of standard of care.
In addition to the pulse oximeter, what is the standard of care type of equipment that is necessary?
Okay, so he did have IV equipment, but he did not have an automated blood pressure cuff. That's a cuff that checks your blood pressure so you don't have to do it yourself. He did have a manual cuff, but it was not in use. You should be checking the blood